Oh, we are live. Hello, everyone. Let me just pop out the chat right here. Set things up. I'm just finishing up a CT scan, and I'm going to share my screen in a minute with you guys so we can report a few more exams today. I have a full day of work still ahead of me. I have already reached the mark of 26 exams, maybe 27. I'm just going to finish this one I opened, and we're going to be on our way to the next one. Just give me a minute. I'm going to share my screen so you guys can see. I've been reporting exams today since early morning. Just took a break to have lunch. It's already 21 past 2 in the afternoon, and we are still here taking down one scan at a time. This is a CT scan. Can you guys see it? I guess yes, you can. This is a abdominal CT scan of a node female. There is a bunch of disease here. I'm just going to finish reporting this and show you guys what this is all about. This is a very curious case. I wasn't supposed to share this, but it's nice. So it's curious, at least it's not nice. It's actually quite terrible. But you know, it's nice to be acquainted of. It's nice to know such cases if you guys are going to be reporting similar cases by yourselves. So you can't teach experience, you can only live it. So let's live this the cracking of this case together. A bunch of simple cysts all over the liver, and a lot of such cysts also in both kidneys. This isn't what we are looking for. We are looking for a much worse disease than this. And I'm just going to fix here my template so we can move on. And of course, I'm going to show you the thing we are supposed to report in this case in just a minute. It's just that I was already reporting, so I'm just going to lose my train of thought if I don't report it right now. Don't worry, we have a few dozen exams and at least 1 hour and a half up ahead of us reporting exams, so it's going to be fine. So this is a case, a 75-year-old female, and it says she has some kind of problem in her pancreas. So I was scrolling up and down, and I've noticed there is atrophy of the tail of the pancreas and a irregular dilatation of the duct. And the dilatation of the ducts comes from the tip of the tail and goes all the way. It's supposed to go all the way to the head of the pancreas, but it stops right there. So if it stops here, there must be a reason for that. So in this portal enhancement phase, venous hepatic phase, I can't really tell because the entire pancreas shows quite the same enhancement. Also on the pre-contrast phase, I can tell there isn't much attenuation difference between any parts of the pancreas, but I can tell there is dilatation of the duct and of course atrophy of the tail right there. So what should we do? We should grab a arterial phase. Why is that? Because the pancreas, the normal pancreatic tissue, the normal parenchyma of the pancreas is very quick to enhance, so it's bright on a in a arterial phase, especially if it's an early arterial phase, which is not this one. This is a regular arterial phase, a hepatic arterial phase. But I can see the head and the uncinate process are bright, and there is a section of the body of the pancreas that is enhancing, but it's a bit less than the rest of the body, the head and the tail. So what is left of the tail is quite bright too, but this part right here, right beside the place, the site where the duct stops, is bright, but not as bright as the rest of the pancreas. So this right here, I'm going to window and increase the zoom so you guys can see. This is a tumor. This is a primary tumor of the pancreas, most probably a adenocarcinoma, which is 95% of pancreatic tumors and almost 100% of such tumors in this age group, 75-year-old female. So let's just do a quick and dirty measurement. 27 millimeters, which is 2.7 centimeters. So this is a tumor, a primary tumor of the pancreas. This is lethal in most of cases. There isn't any signs of secondary disease still, but we know most of the times there is already micro metastasis in such cases and presentations. So this is a major disease. See how the tumor on the portal venous phase, it just disappears, and in the arterial phase I just need to do a very brief windowing maneuver to get a hold of the tumor in plain sight, just like that. If I didn't have a arterial phase or a pancreatic arterial phase, which I don't, it would be quite difficult to measure, but I would be able to say that there was something wrong with this case. So all in all, this is it. This is what I wanted to show you guys. This is a very difficult case for the patient and an easy case for us to make a major diagnosis. So I'm just going to check here my report so I can send it over, and we are going to grab another exam from the queue because there is lots of exams in the queue. So let's go. How's the streaming doing? The streaming is great. If you guys haven't already, please hit that like button and consider subscribing to the channel. It helps a lot. Also, share this stream with people you know enjoys this kind of content, this kind of radiology reporting. Now I'm going to grab a chest CT scan around the emergency. And I'm downloading it. It's a 73-year-old male or female because she has a or he has a ambiguous name. Can't tell. It says here it's a male, but you know, someone did fill up this form and we can trust that. We can only trust our eyes on the images. It says the patient has fever, cough, and chest pains. So we are looking for pneumonia. So this is supposed to be pneumonia. I guess it's a male because I see no breasts. And right there, do you guys see? Let's see if you guys see. Yes, it's all right. You are seeing as much as I am. I'm just going to flip it to the other. Yeah, much better like that. So let's window this a bit so it's properly imaged. And rolling up and rolling down, looking for signs of pneumonia. I see a pulmonary nodule. I see bands. I also see some funky lungs, another nodule right there. This is some funky business right there. Some bronchiectasis, bands and micronodules right there. What is that? Is that middle lobe? Yep, middle lobe right there. Medial segment of the middle lobe. Tiny micronodules. Another nodule, subpleural nodule. Bands all over the apex of both lungs. Some tiny paraseptal cortical emphysema right there. And this is a chronic obstructive pulmonary disease patient for sure. Let's see. Tiny calcifications on the aorta. Some calcifications of the coronary vessels. Yep. Of course, we have as much vertebral arthrosis as we can. It's an old patient, supposed to be there. Axillary regions are fine. This is a very thin patient. He has almost no subcutaneous fat tissue and kind of strong, very muscular for his age. Probably a hard labor patient. Another nodule right there. So we have nodules, we have bands, we also have micronodules, bronchiectasis, and this is it. I'm just going to measure the largest nodule of all. It's 83. 83 is fine. I mean, it's 0.8, not 83. Can't really say this is acute disease. To me, this is all upper airways disease. and can't be diagnosed by a CT scan of the lungs. So I'm going to grab my template. I have a template for chest CTs of patients that is old. Yep, this is it. Um, so we have here bends, bronchiectasis. Just going to report the bends because they are very prominent in the upper lobes. I'm going to emphysema. So it's done. Just nodules, micro nodules. It's tiny emphysema, some bronchiectasis and bends. Nothing that should be considered an acute disease. So they are going to have to look elsewhere. Just going to summarize the scan, the scans report, so it's easier to read. And I'll be sure to put here on the summary of the report that there is no signs of acute pulmonary disease, so it's as clear as it possibly can be. So, yep, just sign it off and send it away. I'm going to grab another here, another CT scan of the chest. Yes, it's here. This is quite the opposite of that scan. This is a female patient. She is 11 years of age, and it says she has some kind of airway acute disease. So I'm going to grab my scan that says everything is normal. The images have already arrived. Oh, this this is far from normal, guys. Far from normal. This is some severe. Yep. This isn't good. So just roll up and down. Right there. Do you guys see it? I'm just going to make a MBR and put it right here. Huh? Holy crap. There is a lot of that, huh? Yeah, hey Tim, what's up? Yeah, it is. So, this is a very young patient. There is a lot of air all over the cervical, deep fascia, deep spaces, and reaching the mediastinal, both ilum or illa, and going all the way through the branching of the airways into the lungs. This is a major emphysema, pneumomediastino of some sort. We have two major causes of this, considering she has a airway disease. This could be to excessive coughing. So somewhere in her upper airways, there is a fissure, a small bruise on the mucosa, and air got outside the airways into the soft tissue right around the airways. This could also be due to some kind of medical procedure which we were not informed of, so they could have bruised her airways or her esophagus and caused this air to go outside where it's supposed to be. Also, we could have some kind of bruise to the esophagus caused by vomiting or some kind of procedure we don't know of. She also may have exploded her lower pharynx by holding by doing some kind of stress coughing, holding her nose while sneezing really strongly, some kind of really strong struggle to cough or to sneeze, which led to a bruise on the airway mucosa, causing this spontaneous extensive pneumomediastinum. So this could lead to a mediastinitis, which is a very deadly disease. And we can also see here a bunch of ground glass opacities all over the place, some atelectases on the lower lobes, and small tiny cortical consolidations, which point us towards acute pulmonary disease, which should also be present somewhere in the upper airways, the sinus, and the middle ear, the pharynx, all that good stuff that comes with viral or bacterial airway disease. So we have indeed acute pulmonary disease, not much, but enough to have symptoms. We also have a major case of this terrible looking pneumomediastinum. Yes, plug the nose and sneeze as hard as you can. It can't be safe for your ears and your mediastinum, just like that. And it's a child, right? It's an 11-year-old child. She can manage to blow her stuff up. So I've seen this happen a few times, but this is the first time I remember seeing this kind of emphysema right here, going all the way to the branching of the major bronchi like that. I know this is possible because anatomically there is folds of pleura just there, but no, this is quite a case. This is a lot of force and a lot of coughing after the first emphysema had occurred, for sure. So let's just report this since we have already cracked this case and there is a few dozen other cases for us to report. So just describing the emphysema, and I'm going to describe now the tiny consolidations or ground glass opacities and atelectases. And no mediastinal masses and no signs of lymph node enlargement. So and this is it. Just going to copy and paste a sentence here that says there are movement artifacts because it's true and it always limits our evaluation because the exam isn't as it's supposed to be. So it's done. I hope she gets over this and goes home in a few days after some major antibiotic treatment. Another chest CT scans. I have already received today a batch of 30 MRIs. It's mostly spinal MRIs and brain and a few joints. And we're going to report them just after we report a few of these CT scans from the emergency. This is a male patient. He is 82 years of age. And it says he has it's downloading here. It says he has pneumonia, a pleural effusion on the right, lymph nodes, also a pulmonary nodule on the left. So this is some kind of follow-up. We have a previous exam here. Yes, that was just a... So I'm just going to download the preview exam images as well. It's here already. I guess you guys are able to see it. Yes, you guys are. Just going to bring it a bit down because of my camera. Right there. So this is lung window and this is soft tissue mediastinal window. It's really shaky. It's all over the place, shaky. And this is as crappy as it gets. But we can always say, we can always describe major disease in cases such as this, because no, it's major, it's large, it's all over the place, so we can do it. But we can't really do any kind of nodular assessment, interstitial pulmonary assessment. It's just not possible. I can tell there is a tiny pleural effusion on the left and a moderate pleural effusion on the right. The heart is enlarged. There is maybe some lymph node enlargement. 1.3 is enough. There is calcification on the vessels. There is some edema of superficial soft tissue. There is, of course, arthrosis, spinal arthrosis, vertebral spine arthrosis, and all that good stuff. You guys know that old people has. This patient is fairly old, 82 years of age is a lot. I can see a consolidation right there on the posterior segment of the upper right lobe. Also some kind of consolidation on the lateral segment of the middle lobe, and there is extensive atelectasis of the inferior right lobe and partial atelectasis of most of the basal segments of the left lower lobe. So there's atelectasis, there are consolidations, and pleural effusions. So we are going to report this, and then we're going to open up the previous exam from the 26th of September. So it's about 10 days back. It should be different from this one, but you know, sometimes it's not. So moderate pleural effusion on the right. Tiny pleural effusion on the left. Some consolidations. Upper and superior and middle lobe on the right. So atelectasis, most of the right inferior lobe, and parts, tiny parts, small parts of the basal segments of the left inferior lobe. So it is always atherosclerosis, the heart is enlarged, and there is lymph node enlargements on the mediastinum. Just summarize it now. So let's compare it to the last exam. Just going to open it up. I'm going to put it side by side. This is today. Where is the previous? The previous exam is right there. So this is, so This is today, right? Today. Okie dokie. This is the last exam. So it's quite the same. That consolidation, middle lobe consolidation is somewhere around here. And that other consolidation is right here. So one consolidation, upper lobe, right there. It's very similar. There is a huge amount of artifacts. So we can't do minor assessment, just large, grotesque, gross assessments. Lactases is just as it's supposed to be. There was a consolidation right here. Can I see that consolidation here? It's quite difficult to tell, but it's probably right there. I don't know. This is just too shaky. Too shaky. It's mostly unaltered. It's going to. So we are done with this one. Let's just go to the next one, because the queue isn't going to solve itself. Now it's a head CT scan of a male, 89 years of age. So this is even older, even. It says he is prostrated. Let's see if it's a actual, it's an actual word. Yes, he is decumbent, procumbent, prostrated. He is lying down and can't get up. He is comatose. He is under some kind of altered, diminished oh yes, he has to be. Come on. Oh crap. That is ugly. Yes. That is quite ugly. So it couldn't be different. Yeah, it is. It is that bad. It has been like this for quite a few days now. I believe this is in over a week, less than a month. This is a subacute major stroke, probably a thromboembolic stroke, because it spares a few sites of the middle cerebral, left cerebral artery, which makes no sense to be spared if this was a complete occlusion. So these sites right there, ill-defined hypoattenuating sites with a mild expensive, mild mass effect, mild, not much. These are stroke sites. This is ischemic. Those, oh, look at that. Those are all subacute ischemic lesions all over the left side of this patient, which is for about 80% of people the dominant side of the brain. So he has some kind of right-sided paralysis and a major conscious limitation for sure. Oh yes, this is occipital, this is parietal, this is temporal, parietal, frontal, and basal ganglia and thalamus. It's all over the place. It's a lot of disease. Still, the cerebral pedicles, the mesencephalum is still fine, and the pons also looks quite symmetric, so it surely is subacute, but not acute nor chronic. So this is major disease. Let's just report this and be on our way. Patient, I don't know, he should be under intensive care for quite some time, and he was home for a few days, at least a week, with such major stroke. So I don't think he's going to die of this, because those terrible first 3 days after the stroke ictus have already passed by, and the patient was lucky enough to survive without proper medical care. So he saved himself without hospital care. Hello, Isaac. Isaac Sue. Hello, what's up? Welcome to the stream. So I have a template here for this kind of situation. Just going to describe the sites of stroke. So just wrote down what I just told you guys in Portuguese in the report. I'm just going to read it, make sure I didn't mistype anything. And we are going to be on our way in a few minutes. Yep, moderate hydrocephalus, supratentorial hydrocephalus right there. Extensive atherosclerosis everywhere, even on the cerebral, the vertebral basilar circulation. And he has gone through ophthalmologic surgery, has had eye lens replaced, lots of brain atrophy, diffuse brain atrophy, as is very common in his age. So let's just summarize. I hope he gets proper treatment as of now on. From now on. Oh, how hypoattenuating is, yeah, it's mild hypoattenuation of the white matter brain white matter. Yeah, this is it. We are done. Let's grab another CT scan. We have another chest CT scan, why not? Right there, chest CT scan. And after this one, we can jump to our our MRIs. I have a bunch of MRIs. This is the 23-year-old patient. He is male and he has suffered some chest trauma. He fell from his motorcycle. So motorcycle are deadly weapons of transportation. Just as bad as it gets to make people fall to the ground at high speeds and break bones. Just downloading. Go, go, go. Let's finish this up. Also, this patient has a left shoulder CT scan. I suppose he has a broken shoulder as well. Why not? He was riding his motorcycle and fell off of it. Yep, the left shoulder is here. Let's do an MPR. Great, MPR is looking good. Let's start off. No way, Tim. Come on. He can't even walk. No, he is going 40 miles per hour on a motorcycle. It makes total sense if you want to kill yourself. No? And run over other people on the streets. Come on. People are just nuts. Man, those electric bikes are something else, really. Here in my town in Brazil, there are a lot of those motorcycles that look like those. They actually look like a proper motorcycle, but they have no exhaust, so we can tell they are electric from far away, and people go nuts all around the cars on the road and making stupid maneuvers. Those are just, I guess those are even deadlier and more dangerous than proper motorcycles. It's just nuts. And they put children and teenagers on those because some of them don't need to be registered. They don't need people to have a driver's license to run them, to ride them. So they put children on them, and children do stupid stuff on the road with those things. Just crazy stuff. So I can see there is some kind of edema right there, especially on the posterior aspect of the shoulder, but some emphysema right there, tiny spots of emphysema. These could be related to fractures. Excuse me. To tiny fractures right there, some tiny emphysema. but I can't really say there are any fractures. There are really any kind of major fractures, any comminutive displaced fractures. It's kind of shaky, It's a trauma patient, it's always shaky. Patients are always in pain. CT scanning is quite hard, so we have to work that out too. Doesn't seem to be any signs of dislocations. I don't know. I guess this is normal. I'm just going to report these tiny signs of emphysema. Which could be nothing, just related to the trauma itself. And some edema of soft tissue parts. And we are going to check the chest CT just in a bit. Oh, those bikes are dangerous, man. And they are nice looking, and they are very low. The tires are tiny, and you ride really low, and it looks so fun to ride. So no, it's really easy for people to get carried away and do stupid stuff and fall off it and crash, and we'll be reporting the scans in no time. And those tiny helmets, they just put those tiny skateboard helmets on and go around at 40 miles per hour and do stupid stuff on the road. Just recipe for disaster. So, soft tissue edema. No fractures, no dislocations. It's all good. So let's check the chest. Chest CT scan right here. It's mediastinum and lung right there. I'm just going to bring it a bit down so I'm not over. Yep. So this is a young patient. We are not supposed to see any signs of chronic pulmonary disease. Anything we see, especially on the left, we could call pulmonary contusions, pulmonary bleeding of some sort, but I can't tell. These lungs seem fine. Let's check the soft tissue, mediastinum, heart, and vessels. Nothing major. Let's just grab this here, do an MPR, and check for fractures of the spine. Spine looks fine. And the rib cage on the left. Rib cage on the left from up to down. If you guys see anything, just buzz me in chat. I can't really see. Let's go for the right side. Since this patient has a left shoulder injury, I suppose he had a crash on his left side, so there isn't supposed to be any right-sided fractured. Sternum isn't fractured. Right side is fractured ribs, because it would make no sense, but we should check it anyway. So I'm also going to check it on the axial view, because some fractures only show up on the axial view. They should have scanned the entirety of the clavicles. They just scanned one. All right. Trauma. They also should have done an enhanced phase, or at least a single phase exam with contrast enhancement, so we could check for vascular acute disease, but they didn't do it because reasons. I don't know. It's supposed to be like that, but people just tend to not do what they are supposed to do, especially in emergency care. Go figure. No, it seems fine. I'm just going to zoom in the spine and look for transversalis processus transversalis fractures, because they happened a lot and we tend to miss them, because those fractures are hard to see unless you do this that I'm doing. This isn't a fracture, this is a failure of fusion right there. Bilateral. This is quite common on the transitional vertebrae from the thorax, the chest, to the abdomen, the dorsal lumbar transition. So this isn't fractures. These are not fractures. These are segmentation anomalies. Right there, not a fracture. Surgeons will tell you this is a fracture because they haven't read the textbook yet. So if they tell you this, they will just point the textbook to them. You don't need to show them where it is in the textbook. You just show them the textbook and they will help themselves and finally agree with you on this. Sometimes they can be quite stubborn, but don't lose faith. It is what it is. So a quick last scroll. Let's roll the images. Tiny micro nodule right there. Another tiny micro nodule right there. There should be a few more of those. If we scroll easy enough, you always see those. So this isn't trauma related. I'm not even supposed to report those. Yeah, it isn't, Tim, for sure. Me too. If it's trauma, if it's real trauma, real enough for a CT scan to be performed, it should be done properly, and properly is always contrast enhanced. So, but you know, I have a bunch of gray hair over discussing this, arguing with people about this. I don't do that anymore because I'm here at home and they are there doing their jobs, and I'm not going to argue with them over the internet, over the phone. They do as they please, and I also don't get more gray hair than I'm supposed to get. So it's a shame, but it is what it is. At least this case is quite normal. Doesn't seem to be a major trauma case. Just yet another normal exam from the emergency. Just describing the micronodules, pulmonary micronodules. And we are going to be on our way to report those nice MRIs. Yep. Let's go for MRIs. Just going to. Yep. Let's grab a lumbar spine MRI right there. Oh, I have to do a quick fix right here. I have to go for my digital signing thingy that has expired. Just a second, guys. Down. Going to let me open up the exam in a bit. Let's go. Can't open that. Some bug on the system. It's okay. Lumbar spine, 53 years of age. It says it's a male patient. And of course, let's see why we are going through these images. What is wrong with this patient? This is a T2, sagittal T2, non-fat saturated. This is a STIR sequence. This is T2 weighted or liquid weighted plus a inversion recovery pulse to saturate fat signal. You guys know. Just going to repeat myself for people that are watching us for the first time. It says patient has pain. It's feeling pain for about 2 weeks, especially on his right inferior limb. So I agree. This is a very painful disease. I guess you guys have already seen it. There is an extruded disc right there, L5S1. Another disc extrusion on L4, L5. This is tiny, this is major. There is migration of the fragment, disc fragment, towards the pedicle level of S1 in its most prominent side of migration is on the right. So the right there, it's compressing the nerve roots on the right. So it makes total sense for this patient to be complaining of his right side. Look, there is moderate stenosis of the right neural foramen right there. Textbook case of such painful presentation of a disc herniation. This disc herniation is mild. This is a severe case. There is moderate stenosis both of the spinal canal, the vertebral canal, and the right neural foramen, I don't know. You guys decide. Just sip my coffee. It's really cold and delicious. There is fat infiltration of the perivertebral muscles right below the sites of disc herniations, as always. Also moderate arthrosis of the facet joints, thickening of the yellow ligaments, right there, thickened, and the other neural foramina seem fine. Conus medullaris is fine. Other nerve roots are okay. There is some chronic degenerative disease of bone. Let's see if there is edema somewhere, anywhere. Is there bone edema? Not much. Let's see T1. T1, there is fat substitution, which is very visible on T2 too. So this is a very nice case, very instructive, very nice case to look at, to be quite sure we can tell why this patient complains of right-sided lumbar pain that goes right to his lower limb. Yeah. Well, this is my first cup of coffee today. I was already complaining of a headache because I hadn't had I was coffee free until about 2 o'clock in the afternoon, so I have no headaches now. So just plain straight coffee. The best coffee you can get. Just going to fill up my cup, my mug in a few moments. Just going to finish up a few more of these with you guys because I have to reach at least the 70 reported exams today. So 2 disc herniations and quite some stenosis right there. Just yep. L4, L5. Road base extrusion, posterior extrusion. And of course, our major culprit of patients' complaints. Oh, there is clear signs of nerve root compression. Nerve root should lead, mostly leads to cauda equina syndrome, which is quite painful and bothersome. Hypertrophy, nerve root compression, moderate arthrosis. Let's just summarize it to make it easier for the physician to read and understand it. And we are done here. It's just down. So another lumbar spine. 70 years of age, female, and it says she has pain. She has pain. She is in pain. She is in pain for about 3 years, and that is what it is. That is all that we have. This is an useless coronal T2 sequence that helps no one. This is a sagittal T2. Nice. Nice, well calibrated machine. Not the best, but good enough. T1, sagittal T1, no fat saturation, good for morphology, moderate arthrosis, no fractures. I can already see there is hypertrophy and fat infiltration of perivertebral muscles. Nerve finds the intervertebral foramina, the neural foramina are normal. Conus medullaris, yes, normal. Nerve roots, fine. There is some protrusion of the discs, really mild. A tiny fat spot right there, which is most probably a hemangioma. 1.0 in L4. Nothing major. Let's see the fat saturation sequence. Look at that. That is bone edema and edema, capsular synovial edema of this facet joint right there. This is quite painful. It's quite different from the other side. So this is acute. This is just chronic. So this could be the case. This could be the motive for this patient to be complaining of lumbar pain, lower lumbar pain, lower back pain, hypertrophy. It's not moderate. It's definitely a severe arthrosis right there. I'd say it's severe. Thickening of the yellow ligaments. Yep. Let's see which side is that. Not the right side. It's the left side. It's L4, L5, and especially L5S1 facet joints on the left. It's there. That's the cause of the patient complaining of pain for sure. So let's just do, I'm just going to grab my template. That is a template. I have a template for that. Just going to slightly modify it a bit. So I'm going to call on these tiny protrusions right there. Right there. Do you guys see it? Just tiny, tiny protrusions, nothing major, but it is what it is. And I can say that is a tiny rupture of the annulus fibrosum, maybe there too, of those discs, which could be painful on themselves. Hey guys, if you haven't already, don't forget to hit the like button and consider subscribing to the channel and share this live stream with people you know enjoys diagnostic radiology. It helps a lot and it's quite easy. It costs nothing to you guys, but it goes a long way to helping the channel to grow. We are still we haven't even reached the 100 subscribers mark. I hope we do in the next few weeks, because you know YouTube is tough. YouTube is a bitch. It just won't show my content to people. It shows sometimes and then it spends like a few weeks not showing anything, and then it just shows random stuff to people. It really doesn't make much sense. I've been trying to figure stuff out, and I just gave up because it's frustrating. I'm just putting as much content out as I can and doing these live streams and see if it works. As much as I can tell, live streams seem to be best, but you know, it is what it is. But if you guys share this live stream and hit like and you know do all that stuff YouTube expect you guys to do, leave a comment, I guess we can boost this channel up and make it show on people's timelines and stuff. I hope so, at least. It might work. Oh, it was the left side, right? Yeah. So the facet joints on the left sides of L4 and L5 S1, L4 L5 and L5 S1 show signs of acute disease, not just chronic disease arthrosis. No stenosis, no nerve root damage. And this is it. Oh, it's the right side, right? Or is it the left side or the right side? I can't remember. Yeah, left side. It's the left side. Okay. Severe arthrosis. Yep. Hypertrophy of those perivertebral muscles. We are done here. Another sip of my awesome black and cold coffee. And let's see. We have been, oh, it's already 1 hour and 30 minutes of live stream. Let's just grab a brain scan so you guys can have some fun checking out a brain MRI. So this is contrast enhanced. This is a 69-year-old male. I'm downloading the images. It says he has, what is it? He has a stroke. He has had a stroke sometime in the past. Nobody says when, but he is unable to walk and has some kind of tremor in his upper extremity. So it seems like he has had some stroke, not just a single place was hit. So this is a sagittal T1, no fat saturation, shaky. All full, filled up with artifacts. There is clear signs of atrophy. Let's go for a T2, axial T2, no fat saturation, clear sign of brain atrophy. I can see lacunar insults, lacunar strokes all over the basal ganglia. Major white matter disease, microvascular disease, moderate hydrocephalus. There is also multiple ischemic lesions on the cerebellum, the pons, the cerebral pedicles, the thalamus. This is a chronic microvascular patient. This is one of those cases of dementia related to microvascular disease for sure. Yep. Look at that. And that. This is a flare. Oi, amor. Não. Sério. Por quê? Porque eu não sei, amorzinho. Não tô acostumado com aquela cama. Deixa eu terminar aqui que eu tô em live, tá? Let's go. Flare says as much as T2 says. I guess this could be some sign of brain bleed, old brain bleed. This is an SWI sequence, a susceptibility weighted imaging sequence. Yes, there is some blood deposits right there. So this is probably a scar of a hemorrhagic, a bleeding event, quite common. Small sites of previous microhemorrhages right there on the cerebellum as well. So this is a chronic hypertensive patient with diffuse and severe microvascular disease and all its possible presentations on MRI. It makes total sense for this patient to have multiple disorders related to these many strokes, previous strokes. So all you have to do now is gather all this information in a very quick, objective, and easy to understand manner and put it all in our report. Contrast enhancement makes no difference in this case because this isn't necessary. In T1 we can see how bad those lacunar, those small stroke sites are all over the parenchyma. It's pretty bad right there, and on the pons, mesencephalus, and all over the place. Also the cerebellar parenchyma is hit, has been hit with such events right there. Blood products, show up as low signal intensity on the SWI sequence. So I have a template for such cases, of course. We need to see the size. We have to do a visual assessment of the size of the hippocampus. See, hippocampus are of perfect size. They are no, the dentate gyrus is just perfect. Although this isn't properly scanned, but no, there isn't a single sign of hippocampus atrophy. So this isn't Alzheimer's disease. This is microvascular, severe microvascular disease, which leads to vascular dementia, usually related to diabetes and hypertension. So I'm just going to describe the many lacunar infarcts. Yep, coffee. And that hemorrhagic stroke scar on the left, and the moderate hydrocephalus, and the hippocampus are fine. Just going to stress that out because people tend to call every dementia Alzheimer's, and we know it isn't like that. It is usually superimposed with other causes of dementia, and this case is a classic case of not Alzheimer's disease. This isn't Alzheimer's disease. This is microvascular dementia. It has a similar early stage presentation usually, but it tends to be much different from classic Alzheimer's as it progresses. And are we done? Yes, I guess we are. We are done. I'm just going to put a small here saying a small phrase here saying there was artifacts, movement artifacts, and we should be good to go. So I guess this is it for today. Thank you so much for tuning in and being around as we read and reported this mini exams. This is already, we have been here for almost 2 hours. Thank you so much. And I'll see you guys in the next live stream, most probably the day after tomorrow, I don't know, maybe tomorrow. I have to check my schedule. I have to have this free time at home to be able to stream for you guys. But don't forget to subscribe to the channel and turn on that notification bell. So as soon as I show up online, or as soon as I schedule the next live stream, I'm trying to schedule them at least a few hours before I actually can go live. So you guys will go, you will receive the live stream notification. And in the description below, I left a link for our Discord server. There I post the notification also, and we can chat and all that good stuff that happens on Discord servers. It's free, it's for everyone. So if you're interested, just click that link and join our Discord community. So thank you so much, and I'll see you guys in the next live stream.